Welcome to everyone, and thank you so much for taking the time to join our webinar today. I'm really delighted to see so many people joining us online and really looking forward to a packed hour and some great discussion with our expert panelists. I'm Eleanor Wheeler, one of the members of the Lung Cancer Policy Network's Secretariat team, and it's my pleasure to introduce the session today and to give you an overview of what to expect. So a quick look at our agenda for the session. We have packed a lot into 1 hour. To set the scene for the day, we will hear a brief overview of the most recent network's report, Time to Act, Improving Lung Cancer Care Through Timed Targets. We will then enjoy 5-minute presentations from 4 of our network members. They will each present an example of timed targets in practice from different locations around the globe. Following this is our panel discussion, and we encourage you to submit your questions for this as you listen to the presentations throughout the session. I'm then going to hand over to my colleague Jessica to give closing remarks for the session. Just on a housekeeping note, we are recording the session today, so you'll be able to watch this back on the Lung Cancer Policy Network's website. And as mentioned, you're really welcome to share any questions and comments that you have throughout the webinar session using the chat and the Q&A box. So before we dive into timed targets, I'm going to give a brief overview of the Lung Cancer Policy Network. The network was established back in 2021, and it's grown and developed over the last 5 years into a global network with members from 39 countries at the moment. The network brings together expert clinicians, patient advocacy groups, academics, industry partners, all with the shared aim to make lung cancer a policy priority. And some of the areas that the network particularly focuses its attention on are around increasing earlier detection, accelerating the adoption of LDCT screening for lung cancer, and also optimizing care for lung cancer across the whole pathway. So taking part in the session today are 4 of our valued network members, all of whom I am absolutely delighted to welcome as speakers and also discussion panelists. So a welcome to Dr. Yon Wook Kim, to Professor Dragana Jovanovic, Dr. Zulfika Otti, and also Professor David Baldwin. Each of our speakers today will be sharing a quick-fire presentation that brings the use of timed targets to life. And before we delve into those, my colleague Jessica Hooper is going to give you a brief overview of the newly published report. So over to you, Jessica.
Thank you so much, Ellie. Yes, as Ellie said, I'm Jessica Hooper, a senior researcher at the Health Policy Partnership and member of the Lung Cancer Policy Network Secretariat team. So before we hear from our panelists, we'd just like to share a short background on why timely lung cancer care matters and how time targets can help achieve this. So lung cancer is the world's leading cause of cancer death, and untimely care places a heavy burden on individuals and health systems. When people wait for diagnosis and treatment, the consequences are serious, with reduced chances of survival, diminished eligibility for curative treatment, and profound anxiety and distress for the people directly affected and their loved ones. The economic toll is equally stark, with tracheal, bronchus, and lung cancers projected to cost $3.9 trillion globally between 2020 and 2050, and premature deaths placing strain on national budgets and productivity. But much of this burden is preventable, and improving timeliness within existing health system structures is one of the most immediate mechanisms available to health system leaders. Time targets can help with this by setting timeframes for diagnosis, treatment, and other aspects of care, and offering a practical way to improve outcomes and accountability. But While they are used in many health systems, they are often inconsistently defined, poorly implemented, or not met. In England, for example, the 62-day referral to treatment target for 85% of people with cancer has not been met for over a decade, impacting the experiences and outcomes of millions of people and stretching health system capacity. A key reason targets fall short is the absence of a clear, agreed definition of what constitutes timely lung cancer care, and only a few national audits have examined lung cancer care in detail. Existing guidelines also differ in the time limits they set for each phase of care. For example, many lung cancer guidelines in Europe do not establish a specific time frame for diagnostic referral, and as guideline development and timeliness of care studies have been predominantly conducted in Western countries, current standards are unlikely to reflect all contexts. Greater international alignment on time targets and benchmarks would give health system leaders a reliable framework for measuring performance and driving improvements. Shared definitions for the timeliness of lung cancer care, alongside clearer descriptions of time points and how they are captured, would help health system leaders identify where delays occur, learn from one another, and adopt targets and support better outcomes. As health systems differ in capacity, resources, and readiness for change, the success of time targets depends on understanding what enables their effective implementation. We need to understand who experiences untimely care and why, and remove the system-level barriers that cause these issues, while building policy frameworks that make improvements sustainable. And as time targets are increasingly being used worldwide to accelerate lung cancer diagnosis and treatment, important lessons for future implementation can be learned. This will enable countries to build stronger, more responsive systems that deliver timely lung cancer care fit for the future. Ultimately, driving meaningful impact requires an iterative approach, defining clear, context-appropriate targets and addressing resource gaps and system bottlenecks, while also monitoring performance over time. I'll now hand back over to Ellie, who will introduce our panelists, who will share insights from real-world implementation of time targets for lung cancer care. Thank you so much.
Thank you, Jess, for that overview. The report does a really great job of bringing together and analysing evidence and practice from across the globe. The link for it will be shared in the chat, so please do download it and enjoy reading that in more detail. Now, the next section of our webinar provides the chance to hear from our 4 network members, all of whom provided the case studies that are featured in the report. So as we listen to these 5-minute presentations, please do share any questions that come to mind for the speakers in the Q&A box, and we'll be really pleased to incorporate them into the panel discussion that will follow these presentations. The next speaker, or the first speaker that we're going to be hearing from is Dr. Yeon-wook Kim, who is Professor of Pulmonary and Critical Care Medicine. And he will be talking to us today about timed targets from diagnosis to surgery in South Korea. So welcome to Dr. Kim. We really look forward to listening to your presentation.
Yes, hi everyone. Thank you, Eleanor, for the nice introduction, and Lung Cancer Policy Network for having me for this talk today. It's a real pleasure to kind of introduce what we have and what we are doing for timely diagnosis and treatment of lung cancer in South Korea, and also very excited to learn from other countries and other members as well. So next slide, please. So I will start with the quick overview of the lung cancer epidemiology and statistics in South Korea. So despite the rapid drop of smoking rates in Asia and South Korea, we still have a kind of stable lung cancer incidence countrywide. So these data are all age standardized. So what we see is a kind of a drop in incidence in the male population, but what we see instead is kind of an increase, gradual increase of lung cancer incidence in female population. And this attributes to several factors, including the more use of imaging, and also we are looking for like other risk factors beyond smoking. Next slide, please. And as shown in the past slide, lung cancer has a high burden, especially in Asia, accounting for more than 60% of all cases and close to 50% of all deaths caused from lung cancer worldwide. And not surprisingly, lung cancer is the number one killer attributable to cancer deaths in South Korea, accounting for 25% of male and about 15% of female cancer deaths. But however, we are seeing a good improvement in overall survival. And so in the right, we can see the improving 5-year survival of all lung cancer patients, which is thankful for the increasing implementation of lung cancer screening, early detection, and advances in treatment and diagnosis technologies. Next slide, please. So this is a nice overview of the overall Korean healthcare system. So what I think is very unique from the US or different Western countries is the single payer universal insurance system. In Korea, it covers over literally 97% of all Korean population, and the rest of the 3% are actually Medicare. So all codes are also covered by the national health insurance system. In Korea. So it's a universal healthcare system. And it covers all claim codes, all insured medical care, all surgeries, all procedures, and all prescriptions. And all these claims are kind of recorded in codes in a system named HIRA. And so the relevant targets are all relevant to cancer care are monitored through this HIRA's regular quality assessment and public reporting of hospital level performance, which encourage institutions to track timelines while maintaining overall care quality. So quality indicators are defined in advance, assessed using standardized criteria, and their results are shared publicly and used in broader institutional evaluations. Next slide, please. So this is the evaluation of adequacy of lung cancer care, the current form which the HRIA system has. So in the left is the form that they used in the past. And as we know, these kind of quality indicators get revised and improved after discussion, after experience. So for now, these are in the right, we have these factors that are evaluated by the HIRA system that serves as a quality indicator and surrogates of evaluating the hospital healthcare system. So what we have is the rate of multidisciplinary consultant rate for lung cancer. And the time target we have is surgery within 30 days of a confirmed lung cancer diagnosis, which is indicated for surgical treatment according to international guidelines. And we also look at critical ill patients, how the percentage and patient education and counseling sessions, and the hospice counseling rate for terminal stage patients. And for outcomes, there are surrogates such as surgical mortality rate, readmission within 30 days of discharge following surgery, so patient admitted to the ICU before the mortality, and patient receiving chemotherapy near the end of life. So most of the time targets are kind of focused on the surgical treatments. Next slide, please. And so why would it be just like 30 days, 1 month? So these data actually come from some our own national analysis on cancer care and cancer epidemiology on mortality. So this data actually is an analysis of the national health insurance database data, and what they looked at is on lung cancer outcomes, including mortality, according to different factors, not only stage, but all demographics and clinical factors. So what they saw is that when adjusted for multiple factors and other factor covariates, those who received surgery after 31 days had a significantly lower survival rate compared to those who received surgery at the early phase. Next slide, please. So time to surgery is the one time frame, the time target we have in the nationwide Korean system. But we know that time to care should also be measured and monitored across various phases. So I'm pretty open and very interested to hearing from other economies and countries as well. And especially, I believe in each country we have different healthcare systems leading to different concerns and discrepancies in diagnosis and treatment. So that's why the Korean system actually kind of focused in timely surgery, because for diagnosis, there were kind of less concerns on the timely diagnosis because we have a very highly accessible healthcare system to tertiary hospitals. And we know that time targets across the full pathway can reduce delays, prevent disease progression, and improve outcomes. And consistent monitoring would be important because these targets could support better patient outcomes and reducing lung cancer mortality at the population level. So this is what I have for now, and I'm happy to discuss further. Thank you.
Great. Thank you so much to Dr. Yeon-Wook Kim for starting off our presentation session and for sharing such an interesting example, particularly for, very clearly showing the benefits of these types of targets, but also explaining to us very clearly how and why this surgical target was selected as that kind of prognostic marker. So for our next presentation, we will be hearing from Professor Dragana Jovanovic. Professor Jovanovic is a senior consultant at Acta Medica and Meliora Clinic, and is also president and founder of the Educational Center for Respiratory and Palliative Medicine. She will be presenting on the use of timed targets in Serbia. So welcome to you, and thank you very much for your presentation.
Thank you very much for the invitation, and also I would like to thank for all these so valuable actions that your team is conducting for years, has been conducting for years. I would like first to present, if you may, the next slide, just to present what the difference in healthcare system in Serbia is from other countries. First of all, public health system covers around 99% of our population, but unfortunately, in most cases, access to timely services is very limited. The Ministry of Health oversees the organization and governance of the Serbian health system, so it is centralized, and the Ministry of Health is also in charge for infrastructure investments and also for all decisions regarding human resources, regarding specializations, etc. On the other side, we have, in fact, the Republic Health Insurance Fund, which is a national one, which is, in fact, made by contributions mostly and some taxes. And on the annual level, all hospitals and also health institutions, they have contract with the Republic Health Insurance Fund. And it is contract on salaries and also on some on drugs and some medical devices. In Serbia, the DRG system has been implemented already several years, but unfortunately, speaking about salaries, it is not recognized because we have no performance-based payment. What is a worrying problem is higher and higher rates of out-of-pocket payments, about 45%, to private clinics and hospitals, which is due to the need for timely care. And another problem which is present now for a few decades is systemic health corruption, which is perceived by general population as the most prominent one for years. The next slide, please. Now, what about lung cancer in Serbia? Here are some facts. One good thing in Serbia is that from the beginning of oncology services, it is now already 50 years, it was established by decisions of multidisciplinary teams called consilia for each patient with diagnosis of cancer. So nothing goes without the decision of multidisciplinary teams. Serbia, unfortunately, is at the top of European statistics for both incidence and much more for mortality from malignant diseases. And lung cancer is the leading cause of cancer incidence and mortality in Serbia as well. And last year, it is the first time that it is the leading cause also among females, not breast cancer, but lung cancer. It has rising incidence over 3 decades, and it is, of course, ranks among the top countries in Europe for this lung cancer mortality. Few important things that have influence, first of all, heavy burden of tobacco-related death. Around 40%, 41% of adult population in Serbia smoke, and it is like that for years, despite so many programs, so many projects. Smoking is banned in public areas, workplaces, and in public transport, but it doesn't apply in bars, restaurants, etc. The other thing is air pollution. Serbia is among the 3 most polluted countries in Europe for years. So that's why the results of huge international research that has been performed by Berg and Associates and presented at World Conference for Lung Cancer in 2021 show exactly Serbia at the first place, ranking the first by deaths that are present from that are in fact because of lung cancer in the population old between 50 and 70 years of age. The next slide, please. Now, the delays in lung cancer care in this situation, as described, are numerous, and there are some key factors. We have bottlenecks at almost every stage of lung cancer care pathway. First of all, it is appointment waiting times for a respiratory physician, which is often too long, 2 to 3 months. Only if emergency cases are perceived by primary doctor, then they have a rapid access to all other specialties. Then also access and turnaround times of diagnostic testing and also treatment. Waiting times for diagnostic, for pathology report, for bronchoscopies, for molecular analysis is most often too long, and also the same is for treatment procedures. One of the issues is lack of necessary equipment and healthcare professional staff in different extent, depending which part of lung cancer care pathway is in question. For example, we have PET-CT only available in 2 major centers, and most recently one private municipal clinic is opened with the high cost of PET-CT who can afford it. And that's why most of our patients that go to surgery, they go only with CT scan, not with PET-CT. Also, specialist palliative and supportive care is very rarely available. There may be a dozen or so specialists up to now, since we have established at the School of Medicine in Belgrade University the specialization for palliative medicine in 2014. And what is really important, it is discrimination in lung cancer quality care that depends on the place of residence of the patient. Why? Because first of all, there are local funds, and unfortunately our patients who live in the inner part of Serbia, they cannot reach easily the tertiary institutions that are most well equipped and also that have most excellent diagnostic and treatment procedures. It is because, in fact, these local governments, they just have their local medical commissions. So patient must be must have, in fact, the approval of local medical commission to be able to go further for diagnostic or treatment to tertiary centers. And what I have already said, of course, majority of patients with suspected lung cancer are pushed to pay out of pocket for lung cancer care to private clinics and hospitals. And it is primarily for timely diagnostic procedures because most people don't have and can't afford, in fact, treatment in private hospitals. The next slide, please. Now, about taking actions, the two biggest university pulmonology centers that are in fact in charge for diagnostic procedures and treatment, out of 4 in country, they introduced time target that define the upper limits of waiting times for invasive procedures, which is bronchoscopy in over 90%, that should be up to 3 weeks, usually about 2 weeks. Pathology analysis up to 2 weeks, and then molecular testing additionally 2 weeks. And of course, the interval between diagnosis and the start of treatment in most cases is up to 3 weeks. That is, in fact, the aim. And just to mention another important thing that from recently, these 2 institutions have also lung cancer screening pilot programs. Next slide, please. Now, in a conclusion, first of all, expanding time targets across all pulmonology centers and oncology institutions that deal with lung cancer, investing in diagnostic capacity. This must be approved by Ministry of Health. And this means that equipment should be obtained from bronchoscopists to other things. And also shifting performance monitoring towards quality outcomes would help reduce delays. Careful planning is, without overburdening the health system, is essential to ensure timely cancer diagnosis. And it needs as a precondition to have monitoring of the time and quality of medical services during lung cancer care. And incorporating time targets then into clinical guidelines and standards of care would be precious to ensure targets that are measurable and clinically meaningful. It means to go step by step in order to achieve the desired time targets. Thank you. This would be all from me.
Thank you very much, Professor Jovanovic, for your presentation. And I think that you very clearly explained, the importance of ensuring that time targets are measurable, as well as being set in that first place, as well as giving us a bit of a sense of the specific delays and the issues around access to timely care that are being experienced in Serbia as well. For our next speaker, I'm pleased to invite Dr. Zulfika Otti to present. Dr. Otti is a medical oncologist at Townsville University Hospital and also senior lecturer at James Cook University in Australia. And he will be presenting for us today on the optimal care pathway for lung cancer in Australia. So over to you, Dr. Otti.
Thank you, Eleanor, and thank you, Lung Cancer Policy Network, for inviting me to present my experience implementing the optimal care pathway for lung cancer. Australian health system has several optimal care pathways for common cancers, including lung cancer. So as you can see in this slide, these are the time frames in the national optimal care pathway. So the initial investigations by the GP should be provided within a week of consultation. And the specialist appointment should take place within 2 weeks of GP referral. Diagnostic tests should be completed within 2 weeks of the first specialist appointment. And treatment should begin within 6 weeks of specialist referral. So these are the time frames in the optimal care pathway. Although this is not mandatory, most of the health services try to obtain these time frames. Next slide, please. So I work in North Queensland, which is a semi-tropical area and covers a vast area about the size of France, maybe more than twice the size of UK, but it is sparsely populated. So as you can imagine, the challenges we face in diagnosis and treatment for lung cancer as well as all the medical conditions. And there are very remote rural population as well as indigenous population. Although Australia has a very world-class healthcare system, but the outcomes are much worse in rural, remote, and indigenous population. Because there is always workforce shortages, lack of GPs and specialists, limited access to investigations like PET scan, CT scans, and after biopsy, the molecular testing takes time because it has to go to a major center, and patients has to be transferred from small regional hospitals to Townsville Hospital for complex diagnostics. And there is always delays in each of these steps. And there was a lack of coordination as well. And administrative systems also contribute to delays. Next slide, please. So we have done several steps to improve the timeliness of people with lung cancer in our hospital. So we have employed lung cancer CNCs to lead the pre-diagnostic coordination, especially for people who are living out of town. And we have been using a lot of telehealth for the last 20 years for triaging as well as seeing patients and treating them closer to home. So that reduces delays significantly. And we have implemented the Townsville Lung Cancer Referral Pathway, which is an online health pathway to help GPs to do the initial investigations and do appropriate referrals. And we have started the Rapid Access Lung Cancer Treatment Clinic for more than a year now, which I would present a bit more in detail. And we'll be starting the lung nodule multidisciplinary clinic soon. As you all know, Australia has started the National Lung Cancer Screening Program last year, so we are experiencing increased number of patients referred with lung nodules. So I think it's very important to have a multidisciplinary lung nodule clinic so that these patients can be seen and managed without delays. And as mentioned by previous speakers, data collection and benchmarkings are always important for improving patient outcomes. Next slide, please. So we started the Rapid Access Lung Cancer Treatment Clinic in August 2024. Initially, it was mainly for patients for chemoradiation and patients who had to travel uh, long distances. So these patients, once they were discussed in the multidisciplinary meeting, the cancer care coordinator contacted the patients and organized travel and accommodation. And they were seen by radiation oncologists and medical oncologists on the same day. And then gradually we increased number of patients and started seeing patients for systemic treatment as well as we are starting the thoracic surgeons are starting in this month so that patients who need surgery also will be seen in the rapid access clinic. So it's mainly run by the medical oncologist, radiation oncologist, and the lung cancer nurse navigator. And we have been using telehealth as well to see patients who live far away. For example, if the patient is not able to travel to the hospital, we usually see them by telehealth usually within 3 days. Next slide, please. So all these patients are seen within 4 days of lung cancer multidisciplinary meeting. So till now, we have seen about 68 patients in the rapid access clinic. 23 are for curative intent treatment, that is mainly chemoradiation, and only 1 patient was for surgery. And rest of them were for palliative intent treatment, either palliative radiation or palliative systemic treatment. So we found that average number of days from MDT to treatment have reduced to 21 days. And for patients referred for curative treatment, it is about 22 days. Hopefully, we'll be able to reduce these timelines further. Next slide, please. Thank you. So in the future, we hope to see more patients in this rapid access clinic and reduce and see them as soon as possible and start their treatment within the proposed timelines.
Thank you very much to Dr. Otti for that presentation, and particularly sharing those numbers at the end and your ambitions around those as well. Thinking back to, the real impact that will have for people living with lung cancer. We are going to stay with the theme of national pathways, and I'm now going to invite Professor David Baldwin to deliver the last presentation of our session before we move into the discussion. Professor Baldwin is Honorary Professor of Medicine and Consultant Physician at Nottingham University Hospital's NHS Foundation Trust and University of Nottingham. And he will be presenting on the National Care Pathway Targets in England. Over to you, Professor Baldwin.
Thank you very much, and thanks for including me in this webinar. Pathways, national care pathways, have been an interest of mine for many years, and we are almost in our 10th year of our national optimal lung cancer pathway that I'll describe to you later. Next slide, please. So we've already covered this. Why do we need pathways and targets? Well, time is absolutely essential with lung cancer. We obviously know that if lung cancer is detected at an earlier stage, there's a better outcome because the chance of curative treatment is much better. And then if people present early and they are diagnosed very rapidly, even in late stage, there is a better outcome. And this is primarily because performance status worsens with time and can worsen quite sharply. And now that we have absolutely fantastic treatment for later stage disease, there's an even bigger imperative to ensure people do not deteriorate while they're on the pathway so that they can benefit from this excellent treatment, because they won't benefit very much if they have very poor performance status. And good pathways meet time targets, as we've heard. Next slide, please. So what are the features of pathways and targets? As we've heard so far, most targets apply guidelines. They are guideline driven. Most of them include an improvement in logistics with investigation bundles, which tend to produce fewer visits. There is an emphasis on faster diagnosis, staging, and fitness assessment run in parallel because they're all equally important. They're often integrated interventions such as smoking cessation, prehabilitation, optimization of medical conditions and support. And then, of course, clear definitions of targets, hopefully for each stage of the pathway. Next slide, please. So what are the objectives of our National Optimal Lung Cancer Pathway? This was first introduced in late 2016-17, and the aim was to optimize, standardize, and accelerate the pathway to treatment, to reduce unwanted variation, because there was lots of evidence of this in the UK at the time, to reduce emergency admission presentations, comply with the national performance targets, which at the time were different to what they are now. Now we have a 28 day target to diagnosis from referral, a 62-day target from referral to treatment, and a 31-day target from diagnosis and staging and ready for treatment to actual treatment. Within the pathway, however, we have many more targets, including a 14-day maximum turnaround time from acquisition of sample to full molecular analysis, for example. Further, with the aim of the pathway was to improve efficiency, improve outcomes and patient experience. Next, please. So you can't really see this, but I think the pathway will be put in the chat so that you'll be able to see it if you go to the web page. Our National Optimal Lung Cancer Pathway now runs into over 20 pages of detail, but this is the single-page summary, which includes timed steps, an area for triage to make sure people with cancer get into our clinics rather than those that have cancer excluded by the initial CT scan. Test bundles tailored for curative and other treatment timelines, best practice details are given in many separate pages for radiation oncology, medical oncology, and for surgery. Next, please. And we also have an implementation strategy for the National Optimal Pathway. And this is essentially recognizing the fact that it's a really big service across the country, and we need to almost spoon feed people to ensure that they follow guideline generated diagnostic and staging processes. So this is one of the diagnostic standards of care. They've just been updated. This will be on the website very soon. And it starts with what the CT scan shows and then moves on to the initial assessment and actions, tests for diagnosis and staging, tests for fitness, and then the requirements before presentation of the patient to the MDT for potential treatment. The idea is to reduce the number of discussions in the MDT and improve the speed of the pathway and guideline directed diagnostics. I'm glad to say that this has been updated from the original version that was done by the Manchester colleagues and has just been updated, and now to include an app which people will be able to use to assist them in following these diagnostic standards of care. So I hope that was a useful snapshot of what we're trying to achieve in the UK, despite the recurrent problem of real problems with resources, which is something that plagues implementation of these pathways. Thank you.
Considerations very clearly. So we're very happy to make sure that we include links as those are live so that people can look at those in a bit more detail. Thank you also to each of the panelists who have shared their presentations. I think it was really good to see this range of examples from different locations and kind of at different levels, as well as what some of those different targets for aspects of care are. So we now move into our panel discussion. So if each of our panelists could turn on their cameras so that we can spotlight you all, and welcome to our audience to share any questions that you would like to pose to our panel in the Q&A box. To kick off the discussion, I would like to ask each of our panelists how we can ensure that timed targets are designed to really drive meaningful improvements in care quality and care outcomes, rather than running almost the risk of being a sort of reporting exercise or an administrative exercise. And if perhaps Dr. Yeon-wook Kim, I come to you first to kick us off, and then we'll open it up to your fellow panelists to feed in.
Yeah, thank you for the great talks, and I actually learned a lot from other healthcare systems. So I believe each economy and healthcare systems, countries face kind of different challenges. For some countries, I believe among the 4 countries that the speakers represent, Korea has the small land and very crowded system with actually pretty high accessibility to resources such as imaging and diagnostic technologies. So for those kind, we have our kind of own needs to kind of distribute rather than be more crowded to send patients to tertiary hospitals, because we have a very, very long queue after the diagnosis to treatment. So that's why our system kind of focuses more on surgery, actually, because they want to distribute again the patients to other, like some well-qualified hospitals. They can get timely treatment. So I think understanding what the current needs are, which in each of the healthcare systems, it will be a great beginning. And actually understanding the evidence, if we have the data, if we have some specific time frames that are proved to actually improve early detection, staging shift, or improving mortality, that will be a good beginning. And what I think is that will be kind of different according to different regions, different population, different healthcare systems. So I think more good understanding will be a very good point to address those things.
Great, thank you. Thank you for kicking us off there. And I could see Professor Baldwin nodding his head there. So do you want to come in and kind of share your thoughts on that one, Professor Baldwin?
Yes, I mean, I think it's that healthcare systems are so different, but the principle is the same, isn't it? We've all said the same thing about early and rapid diagnosis being absolutely key in lung cancer. And it's not necessarily understood in the same way by people who are used to looking after other tumours, because it's not often the other tumours, thankfully, aren't so aggressive. So there is a bit more time. And indeed, in some parts of our lung cancer pathway, for example, a relatively indolent pulmonary nodule, we can take our time. It's not, those people are not so time critical in terms of getting them to surgery as quickly as possible because of the indolence of the cancer. But the average lung cancer is very, very aggressive. And our problem also, it's been coming through here, is capacity in some of the countries. We have fantastic logistics described in the pathway. We've worked out, we're now in version 5 of our national optimal lung cancer pathway, and yet we still cannot achieve the targets, as you mentioned. And that's purely down to workforce. It's purely down to workforce because once you have a very well staffed unit, they meet the targets. And the Manchester unit is one of the great examples of this because they do have better resources, but they use that resource very wisely with their logistics, and it works. The problem in our case in the UK is lack of capacity. Same in Serbia. In Australia, they have more capacity potentially, particularly radiology capacity. So we heard, that there were some good outcomes there. And so I don't think we should stop doing this. I think we really need to push this hard because if you don't have a target there, then people will then just drift. And what it does do, it provides structure and an aim. And I think that's why these targets are so important.
Great, thank you. And Dr. Otti, Professor Jovanovic, is there anything you want to add to those responses before we have our next question? Dr. Otti?
No, I think I agree with Professor Baldwin that, so we need to have targets so that we can aspire or try to achieve those targets and reduce and improve the patient outcomes. So without targets, we don't have anything to aim for.
Mm-hmm. Thank you. Okay. So a question that has come through, which I'm keen to hear your thoughts on. For someone listening today who's interested in pushing for the adoption of time targets in their own health system, is there a piece of advice that you could give them, and which stakeholders should be engaged? For example, clinical, patient advocacy communities. So almost 2 questions in one there. I don't know if anyone would like to speak to that first.
Well, I can start off about a description of how we attempted to implement the National Optimal Lung Cancer Pathway. It's a bit like a guideline. If you don't have really good implementation strategies afterwards, a lot of the work that you've done on the guideline or the pathway is wasted. So we really went for it. We had lots of presentations about what the National Optimal Pathway was, why it was important. We invoked, Cancer Research UK, the Royal Castle Lung Cancer Foundation, NHS England, all the policymakers. When the pathway went out, it went to all the societies, all the patient groups, all of the people that were involved in inputting into the pathway, because we, at the stage of development, we shared our draft pathways with numerous different groups. And this gave them ownership of the pathway. So it was one of the keys to implementation. If you share the development with groups, and then they can see their influence, they're much more likely to adopt it and push it themselves. So there were just two or three things that we did. We did an awful lot more to try to implement it, and we're still going for that. The app is the latest thing for the diagnostic standards of care, which I think is fantastic, done by Matt Everson and colleagues at Manchester.
Great, thank you. So yeah, it sounds like, one thing that was super important was around that joint input and collaboration, and then sort of shouting loudly and over again, sharing that message to the right people. To the other panelists, Dr. Otti, Dr. Kim, Professor Jovanovic, is there any other advice that you would like to share with our audience?
Yeah, I think I would just like to echo David's points, because those are very important points. And I think gathering different voices from different stakeholders, including the patient advocates and the public, is extremely important, because like clinical guidelines are actually mostly driven from clinical trials, randomized trials, but for time targets, we have to more focus on the true values, but for the values, those are not like evidence driven from randomized trials. So we have to get to a point agreement on what kind of values we want as a society, or like a whole entire population. So those would be a good conversation, collaborate between the scientists, policymakers, patient advocates, public, and which I think is extremely important. And we need many discussions to move the needle forward. Yes.
Thank you. Professor Jovanovic, do you want to come in on this one as well?
Well, there are diverse situations in each of these regions. In Serbia, for example, patient advocacy is not well developed yet. There is, for example, one or two associations for patient advocacy, and it is not so familiar with the problems. It is just requesting innovative drugs. So that is one problem. The other problem is, in my humble opinion, that pharmaceutical companies are of great influence in some countries. So they always want the innovative drugs to be spent, etc. So most of their work with the patient's advocacy is in that level. It seems like no one notices that there are so many steps to be fulfilled. Starting from GPs and also from doctors, respiratory physicians, which have a kind of comfortable workplace. And for example, one of the things is that you must face the patient with all possibilities for diagnosis and treatment, and to provide patients with some, for example, also guidelines, because it can influence, but just to simplify, we used to do it, to simplify, for example, those guidelines, time targets, and then they could realize what to do. And this monitoring of the effect is most important, because then you can go out with these results, how much is, for example, mortality of lung cancer decreased in a certain period of time, etc. But unfortunately, in our country, it is also first, most important thing, political will. So.
Yeah, and I think that's a very important point, isn't it? That I think it's come across in the presentations today that all of the situations are quite different, and we're looking obviously very specifically at lung cancer and about time targets, and that sits within that bigger picture of lung cancer care and treatment and diagnosis, and in the bigger cancer kind of space as well. So there's all these layers of kind of complexity, I suppose, that add on top. And almost to go back to David's point around trying to get that messaging through at the same time as lots of other groups are also trying to, you know, ensure that policymakers and decision makers are listening to a whole plethora of different messages and issues. So I think, yeah, we shouldn't underestimate the, you know, kind of complexity and amount of work that it takes, that all of you have demonstrated in terms of creating and building these targets and gaining momentum for them and seeing them implemented and monitoring them. And that, I think, is something that came out of all of your presentations as well, the importance of the quality and the monitoring. We've also had a couple of questions that overlap a little bit. So one around how we can strike a balance between setting almost a gold standard ambition for time targets versus almost a kind of more minimum benchmark, a very realistic minimum benchmark, as well as how different kind of locations that might have less capacity or limited infrastructure can get started. So would be interested again to hear from each of you, you know, where do you see perhaps as a starting point for thinking about timed targets in kind of various locations? Perhaps Dr. Rossi, if I come to you first.
Yeah, thank you. That's an interesting question. I think, so every hospital or really every local health service, there should be advocates or the clinicians who are, advocating for lung cancer optimal care pathways should look at what are the barriers to implementing these timelines. So what are the specific barriers? What are the challenges? For example, uh, do you have enough CT scans in the health service, or do you have enough respiratory doctors, or is there facilities for biopsies? So, and then, we have to advocate to the um, officials, about the lack of, and also publicize these challenges, and then try to get um, funding for, more investigative facilities or more clinicians. So I think this is something which all the clinicians can do in their local hospitals or health services. And also, I think educating general practitioners is another important aspect, because a lot of GPs don't have know the importance of early diagnosis of lung cancer, and people think lung cancer is like a, for example, even if you diagnose it late, it doesn't make any difference. It is sort of a, so there's no good treatment options and all that. So I think this stigma has to be changed, and it is only through educating the GPs we can do that.
Thank you. And do any of our other panelists want to come in on this question?
Just a short addition. So I think addition to that, and a good like solid knowledge on the biology on and risk stratification, I think would be the key, because actually for nodules and I think we are looking at actually asymptomatic patients, many lung cancer asymptomatic. So better knowledge on the risk and biology of getting aggressive cancer versus an indolent cancer or a benign nodule, that would be a good start for triage. And the triage makes kind of like a better distribution of the resources we have in limited. So I think that would be a very good start to implement like a very, very good program with whether it's driven by screening or nodule management. But I think it and education for the pulmonary docs and the in the primary care, I think it will be a good start.
Great, thank you. And then Professor Baldwin.
Well, I mean, I would say that you set a target and that's it. You don't have minimum and maximum standards, because what we found in practice is that if you have a minimum standard, then that's what people follow. So, for example, our time to CT from referral or chest X-ray is 72 hours maximum, and that's the target. 72 hours maximum. They don't do the within 24 hours. Most centers don't, because that's what people follow. So I would counsel people to say, this is the target and that's it. You can give them an ideal situation, but that has nothing to do with what you're actually intending to do. That's my experience in the UK, so it depends on the system.
Great, thank you. And then Professor Jovanovic, do you want to share any final thoughts?
Yes, I would like just to add that, first of all, based on our example, you need a very thorough analysis on the level of doctors, nurses, equipment, so that you can know which one is overburdened as an institution, which not, and how to start to implement these, what do you need of equipment, of training and education, and then how to start with these timed targets.
Thank you very much. So as I had expected, the hour has absolutely flown by, and huge thanks to our 4 speakers and panelists for sharing your experiences, your insights with our audience. In the last minute, I'm going to pass back to my colleague Jessica to kind of wrap up the session and share a few closing remarks.
Thank you so much, Ellie. So as we come to the end of today's webinar, I'd really like to extend my sincere thanks to our excellent speakers for sharing their insights, experiences and perspectives, and to all of you who joined us from around the world. We really hope today's discussion has provided useful insights into how time targets can support these efforts. And to learn more, we encourage you to access our new policy brief, Time to Act, Improving Lung Cancer Care Through Time Targets, using the QR code now displayed on your screen or via the Lung Cancer Policy Network website. And if you have any questions or would like to learn more about the network's work, our contact details are also shown on the screen, and we'd be delighted to hear from you. So thank you so much again for your engagement and participation, and we look forward to continuing this conversation and sharing further resources and activities from the Lung Cancer Policy Network in the future. So we wish you a very good day, afternoon or evening from wherever you're joining from. Thank you so much again.